Hello, I'm Dr. Meghanathiani, a physician from Visakhapatnam. Today, we're going to demystify a condition that I see very often, something called subclinical hypothyroidism. We'll be walking through the expert consensus from the Indian Thyroid Society, so you know you're getting the most reliable, up-to-date information out there. So has a doctor ever told you, or maybe someone you know, that your thyroid is borderline or a little off? It's such a common phrase, but it's also incredibly confusing, right? It leaves you wondering, what does that even mean? What am I supposed to do? Well, that's exactly what we're here to clear up. Here's our game plan. We'll start with what this condition actually is. Then we'll look at who gets it most often, how it's properly diagnosed, and what the potential health risks are. And of course, we'll tackle the big debate, to treat or not to treat. We'll wrap up with a clear consensus on smart management. All right, let's dive right in. First things first, what exactly are we talking about when we say subclinical hypothyroidism? Let's get a really precise definition. Okay, so here's the biochemical picture. Your thyroid-stimulating hormone, or TSH, is high. Now think of TSH as the gas pedal for your thyroid gland. Your brain is pushing that pedal down, telling the thyroid to work harder. But, and this is the crucial part, the actual thyroid hormone, FT4, is still in the normal range. So the engine is working overtime just to maintain a normal speed. Now, it's really important to know that not all subclinical hypothyroidism, or SCH for short, is the same. We actually split it into two grades based on that TSH level. Grade 1 is where the TSH is just mildly elevated, and that's about 90% of cases. Grade 2 is more severe, with the TSH over 10, and that's the one we get more concerned about because it's linked to higher health risks. So who is most likely to be walking around with this condition? Well, the data from studies here in India gives us a very clear picture. The numbers don't lie. This condition is much more common in women. One large Indian study found the prevalence was 11.4% in women, which is nearly double the rate we see in men. And there's another major factor that plays a huge role. And that second factor is age. This chart shows it perfectly. See how the numbers are relatively low for women in their 40s and 50s? But then look at that dramatic leap in the older population, all the way up to 38.5% in one study. So your risk definitely goes up as you get older.
Okay, so given how subtle this all is, how do we actually diagnose it properly? The biggest takeaway here is that you can't and shouldn't make a diagnosis based on a single one-off blood test.
The Indian Thyroid Society has very clear guidance on this. An initial test showing a high TSH is just step 1. The absolutely critical second step is to wait 2 to 3 months and then test again. This is to make sure it wasn't just a temporary blip. And that repeat test should include not just TSH, but also FT4 and a test for thyroid antibodies. And you might be asking, why the wait? Well, it's because lots of things can temporarily bump up your TSH that have nothing to do with a long-term thyroid problem. Things like recovering from an illness, certain medications, or other health conditions. That's why retesting is so vital to avoid a misdiagnosis. Now, that third part of the retest, the anti-TPO antibody test, is a really important piece of the puzzle. These antibodies are a sign of autoimmune thyroid disease, which is the #1 cause of SCH. If these are present, your risk of progressing to full-blown hypothyroidism is significantly higher, almost double, in fact. It's like a little window into the future. This leads us to the next big question. If the thyroid hormones themselves are still in the normal range, why do we even worry about this borderline state? Why does SHM matter? Let's have a look at the potential long-term issues. The expert consensus points to several key areas of concern. We already talked about the risk of progression. But beyond that, untreated SCH has been linked to a higher risk of heart disease, problems with fertility, fatty liver disease, and even subtle issues with memory and mood. And to really put that heart risk into perspective, look at this number. For people with grade 2 SCH, that's a TSH over 10, the risk of having a coronary heart disease event is nearly doubled. This is a huge reason why doctors take this condition very seriously, especially at those higher TSH levels. The link to fertility is also incredibly important. As this quote explains, it's a known cause of problems for women trying to conceive. Because of this, the consensus is that it's very reasonable to test TSH levels in women seeking help for infertility, because treating the condition can absolutely improve their chances of getting pregnant. So, we've defined it, we know who's at risk, and we know the potential consequences. This brings us to the great debate. Who should actually be treated for subclinical hypothyroidism? This is where things get very nuanced, and it's not a simple yes or no answer. This table breaks down the guidelines brilliantly. For younger adults, under 65, with a TSH over 10, the recommendation is clear. Treat them, even if they don't have symptoms. If their TSH is in that milder grade 1 range, you'd consider a trial of treatment if they do have symptoms. But now, look at the contrast for the very elderly. The approach becomes much more cautious, often a wait-and-see approach, and generally avoiding treatment in mild cases.
Let's tackle one of the most common scenarios I see. What if you're under 65, your TSH is in that mild 4.5 to 10 range, and you feel perfectly fine, no symptoms at all? What then?
Well, the guideline here is very direct. In this specific situation, treatment is not warranted. Instead, the right move is what we call active monitoring. If you have those thyroid antibodies, you get a checkup every year. If not, every 3 years is enough. This is all about avoiding unnecessary medication. Okay, we have covered a lot of ground. So let's pull all of this together into the most important, practical, take-home messages for managing this condition smartly. So here are the key things to remember. 1. A real diagnosis always needs a repeat test. 2. Treatment is not one size fits all. It really depends on your age and TSH level. 3. A TSH over 10 and a younger person is a pretty clear signal to start treatment. 4. In many other cases, especially for the elderly with just mild SCH, just watching and waiting is often the best thing to do. And finally, the most important point of all, this has to be a conversation between you and your doctor about your specific case. And that really is the heart of the matter. This quote from the consensus statement says it all perfectly. Even when we do decide to treat, the approach must be personalized. It's about finding the right plan for the individual patient, not just treating a number on the lab report. So, now that you're armed with all this information, I'll leave you with one final question to think about. Is it time for you to have a more informed conversation about your thyroid health? Thank you for your time.